This is our Health Science 401 group presentation by Elizabeth Keller, Kevin Lokes, Carly Meacham, Christine Nguyen, Tran Truong, and Victoria Venu. Our population are veterans, and our health behavior is post-traumatic stress disorder, or PTSD. Our first learning objective is that by the end of this presentation, survey participants will be able to identify one health outcome of PTSD. Our second objective is that by the end of the presentation, survey participants will be able to identify one effective intervention used to combat PTSD. Our last objective is that by the end of the presentation, survey participants will be able to identify one cultural competence issue for public health workers related to veterans struggling with PTSD. Next, we will discuss cultural competence issues for public workers related to veterans with PTSD. Issues include workers not understanding and researching military culture, policies, and effects of military trauma. Public health workers with little to no military experience and are also not aware of military culture will be using trial and error when caring for veterans. Skilled workers that are not aware of military culture will create an additional barrier to provide adequate support for the veterans and can create further miscommunication. Health workers not understanding the difficulty of upholding the heroic image of being a veteran can be another issue, as the veterans may be struggling to see themselves as these ideal heroes. It is important for workers to understand this and know how to appropriately address them. Another cultural competence issue regarding veterans with PTSD will be the stigma around stress injuries and that they differ from stress reactions, as stress injuries remain active even when the stressor is removed. Public health workers may not be knowledgeable that stress injuries require immediate care, the same as physical injuries. Another issue can be public health workers making assumptions about traumatic exposure, which can create negative attitudes. Public health workers need to be knowledgeable about military culture regarding grief, moral, and fatigue injuries in order to effectively interact with veterans. Moving on to the epidemiological data regarding veterans and PTSD. During 2001 to 2011, 2.3 million U.S. troops served in Iraq and Afghanistan conflict. Using the post-deployment health assessment on returning troops in 2003 to 2004, the prevalence of PTSD was 2.2% for Operation Enduring Freedom and 4.8% for Operation Iraqi Freedom. Using the post-deployment health assessment from 2005 to 2006, over a 3 to 6 month period, active troops with PTSD were 6.2% and reservists were 6.6%. Using the post-deployment health reassessment resulted in active troops with PTSD of 9.1% and reservists of 14.3%.
Specific concerns of PTSD. PTSD occurs in 8% of non-military personnel versus 36% of male veterans. PTSD brings intrusive thoughts, isolation, exaggerated startle response, and creates distrust. This can be very hard for people with PTSD as it creates a lot of tension in their relationships. Healthcare providers need to put into place assistance programs for veterans' civilization transition. It can be hard for these veterans to go from extreme traumatic events to normal life. Approximately 61% of American veterans have used VA healthcare and civilization medical facilities since 2001, which goes to show that they are trying for help. Due to the complexity of PTSD and veteran disorders, it is important for healthcare providers to understand the different war eras and assist with tailored therapy. PTSD is more likely to occur in veterans who were at a young age at the time of trauma, lower socioeconomic status, lower military rank, length or number of deployments, and low social supports. Chronic pain is one of the most reported symptoms of PTSD, where 15% to 35% of veterans report having it. Effective interventions for PTSD. Cognitive behavioral therapy has provided the strongest evidence for reducing the symptoms of PTSD more than any other non-drug treatment, and this is typically a 12-week-long program. There are two types of cognitive therapy: cognitive processing therapy and prolonged exposure. Cognitive processing therapy focuses on the trauma's impact by having the patient identify negative thoughts towards the event, understand that stress, replace the thoughts, and cope with those feelings. Prolonged exposure works for 60% of veterans and involves the patient revisiting the trauma in a clinical setting so that the person may change how they choose to react to that memory. EMDR, or eye movement desensitization and reprocessing, is a newer form of treatment for PTSD that has been proven to be highly effective and is growing in popularity. In EMDR, the therapist asks the patient to make eye movements or follow hand taps at the same time as re-encountering traumatic events. This therapy allows for the patient to focus on other stimuli while revisiting trauma and helps them reprocess the traumatic information until it is no longer a disruptive thought.